Taking care of young males is often a challenge, since most young men don't visit their healthcare providers on a regular basis. Through a collaboration among the American Sexual Health Association, School-Based Health Alliance, Healthy Teen Network, and the Partnership for Male Youth, we've developed a tool for healthcare providers that is meant to trigger questions they may want to ask during encounters with young male patients, even those in the office for a simple sports physical. This instrument for providers is a companion piece to Your Health is Your Power, a self-assessment tool for adolescent males to get them thinking about issues related to sexual health, immunizations, and other issues such as mental health. You'll find both tools by going to ashasexualhealth.org, clicking on the Health Providers tab, and then clicking Tools for Treating Adolescent Male Patients. To explore issues related to the examination of the young male patient, we're talking with Dr. David Bell, who is an associate professor in the Department of Pediatrics and Population and Family Health at the Columbia University Medical Center. Dr. Bell is also the medical director of the Young Men's Clinic at the New York Presbyterian Hospital. Dr. Bell, thank you for taking time to talk with us today.
Thank you.
First, I want to ask you about building rapport with patients. And patients of any age might have difficulty discussing sensitive personal health information with their healthcare provider, and this can be especially difficult for young people. Talk about what providers can do to create a welcoming environment for young male patients, building trust and encouraging honest discussions.
So I think that with any patient, but especially including the adolescent male patient, much of the trust and building of rapport starts almost when they see you for the first time, whether it's interacting with other patients in the waiting room or in the hallway or with your staff. They get a sense of who you are and your personality to some degree and how you treat people. So I would say that as clinicians, we need to be very cognizant of our sort of professional relationships, even in the hallway and outside, because especially teenagers are taking note of it from the start. As we call our patients in, I think the key issue is to treat them with respect and sort of honor who they are, and if they start off being in your office with the parent, introduce yourself to them first, then introduce yourself to the parent, and sort of at some point discuss with the parent about confidentiality and the need at some point to establish a one-on-one relationship with the adolescent, and in this case, the adolescent male, and ask them at a certain point to step out in respect of that sort of process. And then with the young person, it's really about asking questions, listening to them, asking questions openly and with a sort of sense that you're curious with a respectful curiosity about who they are and what they like and who they are as a person. You can state the confidentiality statement and sort of say what you will need to keep confidential and what you may not be able to. Then you can ask the sort of more personal and sensitive questions, such as any questions about their sexual life, to be specific.
Do you ever encounter parents who are reluctant to leave the room?
I have occasionally. Usually it's a red flag for something going on in the family and in the relationship. But yes, I have incurred those issues. But even so, most of the time I'm able to talk with a parent to tell them I'm not really trying to keep anything from you. It really is. They are developing into not only the adolescent as they grow older, but also as an emerging adult. And so it is appropriate that they start to get the experience and also develop the rapport with their physician alone and not through their parent.
I want to ask you about the physical exam. Would you speak to the components that should be a priority with the adolescent and young adult male physical exam?
In the context of the adolescent and young adult male physical exam, nothing's very different than the general physical, except the part that I would stress is that in my experience here for the past 16 years, when there are many young men that come in that are either in their late teens or early 20s that have really never experienced a genital exam. And I find that quite interesting because one, it's a normal part of their body, and it needs to be treated as normal and needs to be treated as something that's just as important to examine in a sense as your arm or your heart. It's not necessarily something that needs to be done at every visit no matter what. There is sort of the context of when you do the exam, such as annual physicals, and particularly if they have any concerns, but it is important to include it.
So I would imagine that the discomfort with the physical exam could be especially acute. What can providers do to make young men more comfortable with that aspect of their visit?
I guess I've been in my position for too long in the young men's clinic. It turns out, I think, that many of the young men somewhat either know that that we focus on sexual and reproductive health, so there's no longer as much of or any sort of hesitation about that we need to do the exam at certain times and in certain contexts. However, I'd say as clinicians that may not have been incorporating the genital exam in their routine physicals, it really is sort of discussing that it's a normal part of the exam. There are very specific medical reasons why we do the exam. One is checking for testicular cancer. One is checking for any lumps such as hydrocele or epididymal cysts, different sort of contexts that are in the scrotum that are something to be noted, not always serious, sometimes very serious, and then making sure, especially if a young man is sexually active, inspecting the skin for genital warts or other sort of skin lesions, as well as lymphadenopathy overall. There have been contexts where in the past guys have sort of tried to defer the exam, but when I've talked them through it, I've found genital warts, which they were concerned about, but seem to have so much sort of angst about the genital exam that their worry over the sort of skin lesions, or they discounted that they were anything of note just because of their lack of experience with the lesions themselves.
Thinking beyond the physical exam, let's talk about other issues unique to young males that providers should be thinking about and talking about with their patients, starting with assessing the mental health and emotional state. What are the key messages there?
I think there are many opportunities to assess and many sort of suggestions that we should always assess the mental health of all of our patients, including depression and anxiety. And many clinicians are opting to either do the PHQ-9 or adolescent equivalent of the depression scale. And I would say it's incredibly important to ask and talk to guys about it, not necessarily stop with those scales, but engage them in a conversation around it. What I find is specifically important for engaging males around mental health. If they sort of subscribe, whether consciously or just unconsciously through our societal messages around the masculinity ideals, they usually will tend to be stoic and usually keep many of their emotions bottled up, which isn't healthy for their mental health as well as their physical health, and and having those conversations to sort of discuss why it's important to talk or to do things in a healthy way to get things off of your chest and sort of process them and deal with their mental health and deal with their problems and issues proactively is better for their health is really important.
Let me ask you about diet and exercise. How would you guide a conversation there?
I think they're two different groups of guys, if I were to, and this isn't an absolute, obviously, but they're the young guys who really want to be fit and the athletes that are fit and wanting to exercise a lot and possibly even go to the extreme of using hormones or to enhance their muscular development. So I think the messages about diet and exercise are very different for them, and obviously very different about anabolic steroid use and supplements. But overall, they are a very health-conscious group, and sort of help them understand diet and exercise in a very specific way. Many of those young men are very attuned to their diet, very attuned to sort of the healthy context of diet, including using omega-3 and omega-6 fatty acids, so their HDL protective cholesterol levels are incredibly high in my experience. So I think they're a very specific group that we as clinicians need to foster continuation of their exercise and of their best habits of their diet, and then sort of manage their expectations and their perceptions about use of supplements and anabolic steroids. Now there's the other sort of dichotomized, there's the group of guys who are obese or morbidly obese who think that being big is good and healthy and that they don't necessarily feel good being smaller. And so that is a very different sort of discussion. And most of the time, I would argue for those guys as well as sort of as the middle group, the big issue is about eating fruit, incorporating fruits and vegetables in their diet on a regular basis, and the health benefits of incorporating fruits and vegetables on a regular basis. Then it's I would argue the main portion from a male standpoint is portion control, and sort of not being sort of culturally propelled to think that eating excessively is being a man. And so one is eating meat, and sort of meat consciousness is sort of synonymous with eating manly as well as eating a lot, and sort of figuring out how to switch those messages to say being healthy is not necessarily eating meat all the time and eating more fruits and vegetables, but also being healthy is having a better portion control and sort of managing and understanding when you're hungry as well as when you're sort of satiated, not stuffed.
Do you encounter eating disorders very often with young male patients?
Overall, eating disorders are a rare group of individuals, and I have in my past, and it's according to the spectrum of eating disorders that sort of we're talking about. So some disordered eating in the context, we can sort of even talk about bodybuilders and weightlifting, and sort of as well as at times, and then specifically for certain types of sports that need young men to meet a certain weight for a meet, they can have disordered eating patterns that may not be a true eating disorder in the classic sense of like anorexia nervosa or bulimia. And then there are a small subset of young men that do have eating disorders in that sort of category of anorexia nervosa and bulimia. And those are rare. I have come in contact with them and had them as patients, but it's not common for me.
Let me ask about substance use. And there's a lot there. You've got tobacco, alcohol, you've got drug use, which you can further break up into drugs like marijuana versus harder drugs, perhaps like crack and heroin. What guidance would you offer providers when they're sort of doing this assessment with their young men?
My guidance is really to ask about it, talk about it, and sort of understand where they are with it. It is according to their population that they're working with, but I would also argue that many of the substance uses span all of the socioeconomic groups. So the wealthy young men who we think from the outward appearance may be seemingly on the straight and narrow, they have the money and the access to some of the drugs that we might not think of at all times. And on the other end of the socioeconomic spectrum, even though they may have more access to marijuana than some of the other drugs, so it's really sort of understanding and knowing your population, but opening up the conversation and sort of talking about or having conversations with your young men about all drugs.
I want to move now to chat about immunizations. Specifically, I want to ask about the human papillomavirus vaccine. HPV vaccination is recommended routinely for both male and female adolescents and young adults, but uptake is lagging, especially with males. Only about 40% of girls have received all 3 doses of the HPV vaccine, and for boys, the number is a paltry 22% or so, even though that trajectory seems to be moving upwards. But still, would you talk a bit about why are HPV vaccine rates so low?
The United States is fairly unique in its attitudes around HPV, and this is not only the public attitude, but also the provider attitude around HPV vaccine. We have to, somewhat right and wrong, associate it with sexual activity, and that's in a sense why it's lagged for girls, and particularly as the research incorporated boys in having positive value for giving it to males, which was, as we know, later than the recommendations for girls. Guys are catching up, but that's one of the reasons why they're catching up. But the reasons both are not being vaccinated at the rates that we would hope are because of providers' biases and sometimes parents' biases about whether their child needs the vaccine at the time that it is recommended. And many, I've heard not only parents, but also heard of clinicians that are delaying the HPV vaccine because the perception that particular kid won't be sexually active for some time. However, the science behind HPV vaccination is that giving it early has better immunogenicity rates and responses for both girls and boys. And in fact, boys actually have a higher immunogenicity response, which is really promising.
What do we need to do to support providers in more proactively offering this vaccine?
The CDC and other organizations are really trying to support providers by giving them messaging to speak with parents and sort of also suggesting to include the HPV vaccine in the conversation with other vaccines equally and not to include it as a side or an additional option, which is when the HPV vaccine gets left off or deferred without sort of coming back to it in a timely fashion.
So if you were talking with a parent who is reluctant to have their child, especially their son, given this conversation, vaccinated against HPV, what would you tell them?
Just like you want your kid to get protected against tetanus, which they do every 10 years, and get their measles, mumps, and rubella shots and their meningitis shots. We need to protect our young people, especially including our young men, against HPV. And if there's a certain sort of thought that we're giving it just to guys only to protect females, understand that that's not necessarily true. The HPV vaccine does protect against cancer and genital warts for males as well.
And that's an important point because the perception about this vaccine for the longest time, and to an extent it's still true, is that this is a female vaccine for cervical cancer, and it's certainly that, but it's much more.
It is much more, and what's phenomenal that we haven't, I guess our clinicians have not sort of grappled with, is that other countries, particularly Australia, has seen incredible decreases in cervical cancer and genital warts on a population level because of their distribution of HPV vaccines to all adolescents.
So, keeping in the theme of sexual health, we'll expand the conversation a bit to talk about sexual health and relationships. And, that probably engenders discomfort for both patient and provider alike. Tim, are providers well-versed in sexual health subjects, do you think?
Many providers are not well-versed in talking about sexual health and relationships. Actually, just even as you speak about that, sexual health and relationships are usually not even talked about in the same context. It's like it's either sexual health or it's relationships, but it's never sort of both in the context of each other. I hope that the new cohorts of medical students are being trained overall in being comfortable with talking about relationships and sexual health, but overall it has never been a major focus of our professional education. And I would say that for myself, it became more comfortable as I kept doing it. And sort of in adolescent health and adolescent and young adult health, it's such a priority to speak about sexual health and relationships that the more I did it, the more comfortable I became with it. But it wasn't inherently comfortable.
So it sounds like, to a degree, it's just a matter of repetition. The more you do it, perhaps the more natural it becomes.
Very true. I mean, if in the United States, we're very reticent about speaking about sex and all the implications about sex, and speaking about sexual health is tied into our ideas and feelings around talking about sex.
And in this area, there really are a lot of things to discuss with young men: sexually transmitted infections, contraception, matters of violence and consent. That's a lot to do in an exam that may be fairly short. What are the key questions to ask, the best messages to impart?
You don't have to do it in every visit every time, and you can also hopefully over time have conversations about each of those issues. And so I would say that for sexually transmitted diseases, sexually transmitted infections, it's really important to engage the young men in conversations about what they've heard about and what they somewhat what they know. I use the sort of concept of what they've heard about and ask them that because they may not know, and they've heard a lot of things, and it in a sense can have them save face for not knowing. But it's about imparting information, and my point to them is like, you're my patient now. I want you to leave my office smarter than when you came in, and hopefully by having this discussion we can do this. And so I engage them in a conversation that is a back and forth. Hopefully sometimes it has humor that we can laugh about things, which sort of breaks the ice and builds that rapport and creates the trust as well. And sort of I give them specific messages about what a guy would see or feel when with each of the infections, as well as having them talk me through the steps of using a condom and what are the issues to be concerned about when the condom breaks, particularly if they're having sex with females, and what sort of are the options. And within the context of all of this, speak to the importance of knowing if they're having sex with female partners, then that they should know about what contraception their partners are on and understand or break any myths that they might have about female contraception. And for STIs, just understanding, for males who have sex with males, understanding about new prevention strategies of post-exposure prophylaxis and pre-exposure prophylaxis, and sort of STI testing overall.
Let's talk for a moment about gender and sexual identity. What should trigger a provider to explore these areas with a patient?
To some extent, we should explore it with all patients at certain times, particularly our younger patients, younger adolescents. As our guys get older, in particular sort of working with males, it really becomes sort of the context of your clinic, as well as how you interact with them and how they interact with you. Sort of my experience, which I don't have a large experience working with transgender patients, but I do have a handful of patients that are transgender and have gender and sexual identity issues or concerns. And so especially one patient that I recall, he had started wearing different items of clothing that signaled to me that something was changing, and each visit there was something slightly different and more than before. And I ended up asking him, was there a change in how he wanted me to refer to him, and whether it's pronouns, what have you, which is the sort of the best, from what I understand, the sort of best practices of starting to have conversations with individuals that are changing or thinking about their gender and sexual identity. And he actually at that point said no, and I saw him maybe once or twice more, and then I lost him to follow-up for about 4 years or so. And then he came back to me, but he was no longer, he had gone through some changes and was now he was calling himself female, and I now treat her as a female, but in my clinic as the Young Men's Clinic, where she feels comfortable coming, and she's referred a number of her other transgender patients, as well as their sexual partners. And so that's been my experience, but it has been mostly a trigger while working with the patient and sort of getting a sense that they are in transition.
And what a fortunate patient to have a provider in a clinic where they do feel comfortable, so much so that they refer others there. And when I was listening to you talk about that, I flashed back to something you said at the beginning of our conversation about like when you're first introducing yourself or meeting the patient, and the parents are there to talk to the patient first and to establish a sense of rapport and respect. And it sounds like you're just continuing with that, and that's probably something that just can't be emphasized strongly enough. Dr. David Bell of Columbia University, thank you so much for taking time to talk with us today. This is fascinating, and I hope you'll come back and talk with us again. I think there's a lot to explore here, so thank you so much. Both the provider and patient checklists we referenced at the beginning of this tutorial are linked on the landing page for this episode, and you can find them also online at ashasexualhealth.org. Thank you for listening, and if you have comments or questions, please direct them to us. The email address is info@ashasexualhealth.org.